Thank you very much, Silke. I'm delighted to be here. And the topic is challenging, I have to admit, specifically after the talk of Hans Härtel yesterday. So I try to do my very best. This is my disclosure statement. As Frau Mate just said, I was an author of guidelines as well, and I have received funding, but this has no relation to this topic today. So this is my final conclusive slide, so just in case you want to leave the room now. Patient safety should be one of our highest priorities in clinical care, and therefore we need reliable systems, and we need good visible leadership and involvement of professionals, of course, and of parents and public media as well. And change, if we do want to change, like the things that had just been recently discussed, we need evidence from research, and we need commitment of all partners. We need trust, transparency, and feedback, specifically if an error occurred and we reported that in a system. So we need good feedback loops in order to have a chance of an opportunity for collaborative learning. And we need some sort of a common sense, like a vision. What do we want to do? And this is based on values. So what is important to us about our work? Of course, beliefs as well. What do we believe about our work? And of behaviors. How do we go about our work? What is acceptable behavior? And even in a blame-free culture, what is unacceptable behavior? The blame culture is based on fault finding. It focuses on individuals and asks who, and it's making assumptions rather than having a good evaluation. It blames, it controls, inspects, and it sorts. And the blame-free culture, and blaming is a frequent phenomenon in medical care. As you can see here, this is just an evaluation of about 2,000 critical incidents reports in an outpatient setting. And direct blaming on individuals took part in about a half of the critical incident reporting system. And it was based on staff factors, organizational factors, patient factors as well. So blaming is a frequent phenomenon, and this is from 2017. So if we want to talk about blame-free culture, or just culture that Hans mentioned yesterday, the safety issue is focused. So we need to have a culture of fact-finding and focus on the process rather than on individual errors. Ask why and not who. Determine the needs and be helpful, hold accountable, hold people responsible for the whole process. Assist and improve the capability of the individuals in the process. And the culture that we have, blame or fear of blame, of course, it affects the babies and their families, so we need to keep an eye on that. Errors or adverse events are frequent phenomena in the neonatal intensive care unit. Unattended events caused by healthcare management occur in about 74 events of 100 NICU patients, and they are related to infections, catheter dislocations. We will hear about accidental extubations later on. So random safety audits have shown that only in 34% we can call medical device use as being appropriate. So this is a problem with regard to the use of medical devices like incubators and ventilators, etc. And in 2% critical incidents occurred during this random safety audit. So what do we need? We need some reporting of errors. So we need to be able to speak up. We need to make root cause analysis. So what's the cause? And learning opportunities. And this is the main aspect I would like to come up with. And as you know, that medical errors or unattended events, they occur in the public media. The public media, they are focused on the personal suffering of patients. They are not focusing on a root cause analysis. What we have to do is to learn from medical errors or from unattended events and do detailed analysis and be open be transparent with public media and specifically with the families of vulnerable infants that we care for. So how do we actually establish a blame-free culture? We need a procedure compliance. So whatever we do, we need compliance, we need commitment in the team. So we need standards, but we also have to teach flexibility. So you have to adapt to the personal, to the individual situation of an individual child. We need effective communication, not only verbally. Non-verbal communication can be wrong as well. Appropriate staffing, this is an important topic, and we need to talk about that with politicians. But only if we have appropriate staffing, which is not fatigued and which allows to do good work, then we can have good teamwork, which is important for patient safety. We need safety measures and no blame response to error. And we need to identify and report adverse events and have no fear to speak up. And of course, we have a complex system. So we have organizational and human factors. And we can learn, as Hans said yesterday, from aviation and Formula One. And it's always, the main point is here, it's always good to have enough staff. About written standards and procedure compliance, we can be very, very detailed about standards and over-regulated, but the standards need to be straightforward and needs to leave some freedom for applications to individuals. So it's rather good to have a good, a short, a crisp standard rather than 5 pages which no one can use. And if you want to do change management, we need to have commitment. I work in one of my research fields is less invasive surfactant administration. I'll just give you an example. You ask an expert in the field, you would like to implement Lisa, for example. You ask, I call her Angela. Angela's, there are several women in Germany, very important, named Angela. Dear Angela, from the literature, I'll notice the huge benefit for preterm infants treated with surfactant using Lisa, and I would like to implement that in my unit, given your expertise and long-term experience. In surfactant administration to preterm infants, I ask you for your SOP. Thank you very much. And then here you go. There is the SOP. And then you give the SOP to all the consultants in the unit. Please find and close the SOP. Lisa, please implement the procedure for all infants as soon as possible. This is not going to work. You need commitment rather than like management-driven change. And what you have to do, or this is my perspective, is we need to involve all the professional groups, the parents and the patient legislative. We need to convene with research and evidence and clinical benefit from Lisa, for example. And we need to do a literature review or have a guideline and share this information, educate the people, and then do training first before you implement a new strategy. And we need the medical device competence as well. So research is the time has come to protect children and young people through research and not from research. This is a bioethics statement from Bobby Farsides in 2013, and this is very true. Change management needs scientific evidence. In order to provide patient safety, we need to have a context, how to implement a new strategy, for example, in a specific clinical context. So research comes first. Sorry. The second is we need to have shared involvement, specifically with parents and families. In a family-centered setting, we need information, education, and training of parents as well. And we need to train ourselves. We need to, Hans Härtel noted that yesterday, we need to have the time to train ourselves in an interprofessional way for systems and devices, and this is just one example of our simulation setting in Lübeck. And this simulation, this scenario training, helps to actually evaluate human factors, relational factors as well. This is a study I would like to discuss briefly from Israel, and these were 72 NICU professional teams, 2 nurses and 1 doctor each in 4 Israeli hospitals, and they made scenarios of different highly vulnerable preterm babies, for example, necrotizing enterocolitis or sepsis. And during this scenario, they had an expert on the phone. And this expert made, in the control group, like very neutral comments. I hope you're going to enjoy this simulation workshop and improve your work. And in the rudeness group, this expert would say, I'm not impressed with the quality of medicine in Israel. This was the first statement. And 5 minutes later, he called again and said, medical staff like you would not last 1 week in my department. I hope that I will not get sick while I'm in Israel. So this was the rudeness group. And this whole experiment was led by a psychologist. So. But the interesting data they came up with was, if you are in the rudeness group, this dramatically affects your performance. So for example, the rudeness group did not diagnose deterioration of the preterm baby in this specific simulation situation. And on the other hand, procedural performance was worse as well. So the atmosphere, the climate in your situation dramatically affects the outcome of the child. We cannot measure that very easily, but we need to make sure, we need to acknowledge that in a way. So how do we move on? We need to learn from adverse events. So the first step is to actually monitor that or to report that. And we have patient safety learning systems in place in many hospitals, or critical incident reporting systems. And these systems can actually monitor underlying trends to allow early detection of future adverse events and collaborative learning from timely investigations and comprehensive notes. And we can provide accurate information for patients or families about the event. We need to communicate to families that the babies that we're treating for are highly vulnerable. They are at risk, and medical errors occur, but we try our very best to minimize the risk of medical errors. And this is always a delicate balance, as you may know from your clinical daily routine. So this is a balance of, I'm responsible, I need to know about risk, I have to be aware of risk, and I hope that I work in a reliable system. So errors occur, and this is just an example from the University of Lübeck. This is the men's restroom after the cafeteria had reopened. And this is not a major disadvantage of the males in that matter. The women's restroom looked the same, so you might notice that this might be, yes, a forum of collaboration, whatever, but I have to say there's some privacy missing. Yeah. So it was just an error that happened. And all of you would say, well, this restroom is just not working properly, and would go to the facility and try to do their best that this is going to be fixed. But in the medical system, sometimes we are very reluctant to report errors, isn't it? Yeah. I think we need to change the battery next time. So for this patient learning system, we have to have this perception that these reporting systems improve actually safety. And we have to have guidelines how to report, what to report, and how the data is actually used. So we need to have a feedback, and we need to have a legislated protection of those who report, and the ability to report in an anonymous fashion. And after that, we need education and training opportunities. And we need a leader who's visible and support this reporting system rather than blaming anyone for reporting. And so we need an open communication, feedback, and a debriefing scenario for errors that occur in a clinical duty. And just as an example from orchestra, Leonard Bernstein was fantastic, but sometimes he just needed very small gestures in a very complex setting of an orchestra. And in an interview he said, I need to trust my musicians. That's That's very important. So we, in our medical system, we need to trust the people and believe that they want to do their best. That's the first thing we have to make sure. But we also need to define behavioral standards. So a blame-free culture doesn't mean that you can accept unacceptable behavior. We need to sanction that, and we need to know who's behaving unacceptable or willingly doing wrong things. So how to establish a blame-free culture? One thing that has arisen lately is peer review. So you get your peers, you get neonatologists, pediatric intensivists from other hospitals to come to your place and have a very open discussion about things that might be optimizable in a way. And psychological support, not only for parents and for us in a supervision fashion, but also to improve actually outcome. And there is one study I just wanted to name, which had shown that a psychologist-led educational intervention results in sustained reduction in infections in the NICUs. And we have done the same. Our psychologist is also interested in infection surveillance. So this is, from my point of view, a very, very strong argument for psychologists on the ward. So to conclude, patient safety is a priority. We need collaborative learning from errors as an integral part of newborn intensive care, and not newborn intensive scare, neither for parents, not for individuals that work on the ward. We need a supportive infrastructure from the leadership point of view, but also from the hospital administration. And we need medical engagement, commitment, and involvement of parents. And last but not least, I would like to quote Maya Angelou. She's a poet from the United States who died in 2014. She said, "I've learned that people will forget what you said. People will forget what you did, but they will never forget how you made them feel." So this is my voice for open communication. Thank you very much for your attention.
Thank you very much for this really fantastic presentation. Any comments, any questions from the audience? How would you, when you were in Lübeck in the hospital setting, and there happens, well, everywhere happens errors, what is your first step to do then in the end?
Yeah, so we have a critical incident reporting system. This is the first step, but we're also talking about daily routine, right? This is some sort of maybe a perfect system. But I have learned that it is important to speak up and to discuss this error, but in a very sort of open, transparent situation, and not. Sometimes it's good to wait for one day, and not to do the first step right after the error occurred, unless people need a debriefing because they are. So this is a situation that you always have to be there for nurses, doctors who are affected from the situation. But to talk about a potential medical error in an analytic way, I would always wait for one day. Mm-hmm. So first step. But the other thing is communication to parents, and everyone knows in this room, and Eva Mildenberger from Mainz knows that as well. If we had like public interest of medical adverse events in neonatal intensive care units, it's very important to talk to the parents who are on the ward during that period of time, and to be very open about specific risks and try to avoid unintended events as much as possible.
Thank you. Any further questions, comments? Use the momentum.
Okay.
Yes?
Well, I have a question. Could you expand further on debriefing? I know that's something in the last few years in my unit we've introduced, actually after every kind of critical delivery we attend, and I feel like it's really improved communication and just education, discussion. We can
Yeah.
all learn something.
Yeah. This debriefing is a very, very important part of talking, analyzing things that happened. And as you say, you know, there might be a time frame between, or there might be a situation that you do that straight after the event occurred. We do both, and it's you need to have, if possible, a relaxing situation, so you sit down and everyone who's involved can speak up, and there should be one person who was not involved who's leading the debriefing. If not possible, like on the weekends, and I'm on call, I lead that. But you know, there are emotional things that affect my own behavior in that situation. Therefore, it is a very, very delicate topic, because we have so many emotional and human factors, relational factors involved.
Yes, please.
Yeah.
Do you have a written standard for debriefing, or do you do it just by your own knowledge? Do you have
Can you use the microphone, please?
Yeah. The question is whether we have a written down standard for debriefing. Yes, we do. Since 2016, we have a 10-minute day ahead sit together on the ward with the nurses. So we take our time, 9 o'clock from 9 to 9:10. It's good for first coffee, and we plan the day ahead, and we look for potential stresses of the day, potential risks, problems, and it's always it's good, because people feel safer, and patient safety is related to how safe do I feel myself. And so this is a good way to start the day, actually, like a team huddle. That's what we call it.
I would also have maybe a last question to continue, because I see here Dr. Jens Schwind standing with sim characters. I'm fascinated from this. What yesterday also the pilot told us about the simulation training. You mentioned this in your talk as well, about training really the team, and training with the team you work, and not with a mixed up of a team from several hospitals. What makes this the difference for really preventing in the end errors? But this communications thing, what you said, when you stress someone, or like yesterday the pilot said, when I have a fight or a discussion with my wife this morning, that influences the way how I'm working.
Yeah.
So how are you doing this in Lübeck? Because I guess many of you are not working like this. And so I'm a fan of Jens, so you should visit him at the Sim Characters booth. And so we work also with this group together to make a research on it, to really implement this tool of simulation. So this would be interesting for me to share this maybe with the audience.
Yeah, I mean, Jens has done excellent work on that, and he's basically the first who has implemented like simulation for a very, very tiny baby, and this helps a lot in our daily routine. We do that. We do simulation trainings every 3 months, not only for our hospitals but for delivery hospitals in our neighborhood, like next 100 kilometers. And this is actually very helpful, and specifically if you want to train communicative skills, because what I said is the non-communication is maybe related to blame as well. Because sometimes a rather junior on-call physician, she said during grand rounds, if you don't say a word during the grand round, there's a problem. And so, you know, I just feel like it's good that we talk about that afterwards and not in front of everyone. But they feel blamed just because I don't say anything during the grand round. So this is very relational and very, very human in a way, and you need to have a sense for that. And simulation trainings is a very good option to train that and to get a good feedback afterwards, because you as a consultant and as a nurse and as a junior doctor, you are all involved, and then there's someone else who's just watching the whole scenario and giving everyone feedback. It's very helpful. And it's not that expensive. I don't get any money from Jens, but he's a nice person, and he's giving you a good deal. So
yeah. So you hear the message, what you do in the coffee breaks. So visiting the booth from Jens and Baxter and all the others who are here in the exhibition area. Yeah, thank you very much, Mr. Härtel. So we would move to the next speaker.